First and foremost, before I tell you about Dr. Finlay, I will say that he is, I think, gets at least a good portion of credit for saving my life. And I'm, of course, eternally grateful to him for that, but we'll learn much more about what that means. And I think Jonathan's philosophy of really being concerned not just about extending life, but about quality of life.
Thanks for joining me today for the very first episode of Craig's Cancer. This series in my life wouldn't have been what it is if I didn't have cancer many years ago. I spent most of my life working in the cancer industry. I've met many survivors and I've worked with the very best doctors. And this podcast will take you on a journey to meet the people I've met along the way.
Dr. Finlay is an internationally recognized authority in the management of children, adolescents, and young adults with brain tumors. Following his training, he held positions at Stanford University, the University of Wisconsin-Madison, Children's Hospital of Philadelphia, Memorial Sloan Kettering, and New York University. And he is most recently, he was director of the neuro-oncology program at Children's Hospital Los Angeles. He was a professor of pediatrics at the Ohio State University and director of the neuro-oncology program at Nationwide Children's Hospital. Jonathan is a two-time cancer survivor, and I think he'll tell us a little bit about that too.
Oh, thank you. You've been very kind in your introduction. Thank you.
I'd like to maybe turn a little bit to kind of our personal relationship and ask you about those many years ago when we met. So I was diagnosed with a germ cell tumor, which you talk about the concept of MRI. Well, MRI was just being introduced and was available in New York City where I was diagnosed in 1992. But something that I didn't understand, so I had surgery, and then Mount Sinai Hospital, where I had my surgery, they said, well, you can stay here, we'll irradiate your brain and it'll get rid of the cancer, but it'll likely leave you with some fairly significant deficits, right? But they said, or you can go down the block and you can investigate the one clinical trial in the whole country that's going on at Memorial Sloan Kettering. So I initially met one of your colleagues, who, to put it lightly, was like talking to a used car salesperson. She was, and this is maybe one of the challenges I think, you I think are very good at working with, if you will, sort of a broad population of children, adolescents, and young adults, but that's not the skill set that all of your colleagues have. And I was, at the time I was 27 and in the room with my parents, she's telling, absolutely, I think probably over dramatized, why I should not stay at Mount Sinai and get cranial irradiation, because I was going to end up like a head of broccoli, basically. So, but I ultimately decided to enroll, and shortly after that, I think then, she left to another institution, and you became the primary investigator on the trial. And what I'd love to hear is your perspective on, I will tell you that it was a very, very peculiar environment for me from the beginning, right? So I was a working person coming every month for my chemotherapy, and then during the week coming in for blood tests, into this environment that was filled with little ones, with infants and young children, and was not well set up, particularly for somebody like me. And yet, your team was excellent and took very good care of me, but it was not a particularly welcoming environment for somebody at my age.
Well, you raise a number of very interesting issues there. Increasingly, let me just address the issue of your age, for example. Increasingly, there has been this tendency for young adults who have tumors that are more associated with children like yours to be treated at least by pediatric specialists because they have greater experience in that regard. And that's become more acceptable. And I think it is also in many centers, if not most throughout the country, the centers have adapted to be more comfortable and able and accommodating of what we call the adolescent young adult, and that's teen into 20s, because adolescents as well have problems dealing with being in clinic with 4-year-olds running around. It is interesting, though, because at NYU, for example, my practice became hugely adult, and we would see a combination of the adults, including some much older adults with primary brain tumors, and the children. And I guess perhaps because I and my nursing colleagues were somehow more sensitized, appreciative of this, and expectant of some of the problems, anticipating some of the problems that could arise, it worked well. And what we found is that the adults felt, with all those kids around them, my goodness, if these little children can do so well tolerating all this, so should I. And the kids just thought that the adults were somebody else's parents, you know, the little ones. And it actually worked well. It was more, and we got information and feedback from the patients, adult and the parents of children in this regard. It was more the nursing and physician staff that had difficulties adjusting to this than it was the patients. But clearly, for it to work well, the nursing staff have to be on board. And I think that's become more and more cell tumors of the brain. And it was then and still remains to the present time of great personal interest to me, because my first cancer that I had at 26 years of age was a germ cell tumor, not of the brain, but as the most common type of germ cell tumor, which occurs in men in their 20s, teens, 20s, and 30s, which is testicular cancer. And mine didn't behave. I had not only a recurrence at just 7 to 8 months after initial presentation, but metastasis to my lungs. And back in 1976, I wasn't supposed to have survived that. So having done so, I think had a profound impact in making me the kind of cockeyed optimist that I have remained, hopefully, ever since. You know, a disease is not curable until it is cured. And I took that attitude with myself back in 1976, although I didn't know much about the treatment of cancer in those days, but responded to people, innovative people that suggested certain drug treatments for me that were totally unproven in those days for testicular cancer. And here I am, 40 odd years later, but I've also applied those principles throughout my entire career and have continued in the last 4 years that I've been confronting multiple myeloma to apply those same principles to myself the second time around. Why should I not expect of myself what I haven't done for decades of my children? Of course, it's a big age difference. And I can say I'm not doing too badly on it, because after 4 years of dealing with this, I'm in a deep remission. I'm in great shape physically as well as cognitively. At least I hope I'm coming off as okay cognitively. You know, and I'm doing very well with this process. So that personal impact not only influenced my interest in central nervous system germ cell tumors, which is an amazingly, as you well recognize, complex set of tumors, but also in my own practice of medicine as a pediatric brain tumor doctor. I think that helped to answer your questions there.
No, that's wonderful. And I think we would say, or I would say that you are indeed a terrific clinician and researcher, but you're really very much a patient advocate, because that comes from self-advocacy at the beginning. And that's certainly what you did. Sounded like you did at the age of 26 and what you continue to do today. And that might lead me to kind of my next question, which is, what kinds of things have you learned from the patients and families that you've worked with over the years?
I've learned so much, both directly as well as indirectly, sometimes through mistakes in conversations. This isn't something how to deal with families that's taught you very well in medical schools. I think maybe it's taught better than it was when I was in medical school all those years ago. But it was something that one learned, if you'll excuse the expression, by the seat of one's pants. And one made errors and one learned from the errors. And it was often the parents that would tell you, this was or it wasn't appropriate, or thank you for this, and that was a great way of doing it, or other colleagues telling you, that was a great way to do things, or you should have done this or done that or the other. But in a bigger way, I have to say that I've learned so much from the patients that didn't make it. Those are the patients that have stimulated me to press on and really try and make a difference and learn from the experiences with those patients and improve so that one could try and avoid those things. Yes, there's no question. One gains tremendous strength, emotional and mental strength from the successes. There's no question about that. But in many ways, it's the failures, if you like, the inability to cure and the loss of such children that stimulates you to really stay the course and work on and work harder to try and improve the outcome. And I should also say that it's seeing children cured of their cancers, but with substantial late effects, both from radiation therapy, from their disease and what have you, that has long stimulated me in the design and conduct of my practice and of my academic practice in developing clinical trials, to say that it's not enough just to cure our children. A primary study goal has also to be to document the preservation and improvement in the quality of life of those children. So, for example, our Head Start trials for young children with medulloblastoma, the most common malignant brain tumor, as I mentioned earlier, for children, which is sought to avoid radiation while at the same time improve cure rate. We had from the very outset perspective, neuropsychological and psychological quality of life, IQ testing and other more advanced testing, and we've published this and presented this repeatedly, actually, through the work of my wonderful colleague, who I think you may have met in the past, Dr. Stephen Sands, who is currently actually Chief of Pediatric Neuropsychology at Memorial Sloan Kettering Cancer Center, where all of this started so many decades ago. And we've continued to do that for all of our 4 prospective Head Start trials over the last, 30 odd years. Mm-hmm. It's become crucial for us to show, yes, we can improve the cure rate, but look, we're also preserving, indeed, in many cases improving, but at least preserving the quality of life of these children through avoidance or minimization of radiation therapy. So my patients have been the ones that have taught me the need for all of that over the decades.
So it seems to me that both what you've learned from your patients, maybe as well as I'm sure your personal experience, you have a really innate ability to understand that there's a balance between extending life and quality of life, and that listening is so important. And so what I'd love to ask you about is maybe more at kind of the healthcare system level, or at least the hospital or institutional level, which is, are we getting better at being sensitive and listening to what patients are telling us? And sometimes they're not directly saying that to us, but there are, maybe their caregivers are saying that, or that we are just seeing it on their faces or whatever it might be. I mean, I think that the experience And this, I think, when did you leave Memorial Sloan Kettering? 1994?
89. That's 87. No, sorry, 89, 1997. 1997. I went to NYU from Memorial. And it was in 1997 where I learned a lot about what you're just asking. Because as I said to you at NYU, as I said previously, a lot of my practice was taking care of adults with primary brain cancer. And it was at that stage that I really learned the truth of the sense that many of us had and often joked about over the years. When I said to you at the beginning, pediatricians are the nicest kind of doctors. Who have a very different approach to our patients than adults do towards their adult practitioners towards their adult patients. I've often felt that you can't BS your children the way you can adults. Obviously, the relationship is different when you've got a parent who's incredibly involved in the care because it's their child that's being treated. But there is no doubt that in general, there is a big difference between the way adults talk with and talk to their adult patients from the way most pediatric oncologists and neuro-oncologists treat and talk with and talk to. But across the board, I would say to you that I do see and I have seen significant improvements over the years, both in the way the parents of young children, the children themselves, adolescents and adults are included and talked with rather than talked at by their physicians.
Thank you. I think that because I was treated way back when, I think that something, and we talked a little bit about the young adult experience. Something I really struggled with, or a couple, is that there was always this assumption that my parents should be in the room, and that
27 years of age. Wow.
Right. And I mean, some of the providers like you, and in particular, I remember my neurosurgeon at Mount Sinai were very, very careful about that. But other folks just assumed that my parents should be there or that they should be included in the discussion, or that I shouldn't be given separate time before we bring in anybody from my family, caregivers, and for part of that discussion. And I think that I'm glad to hear you say that there's a greater level of listening there, but I think that was certainly a challenge for me. I think something else that was took me a long time to unravel was that as you well know, brain tumor treatment is physically, emotionally, mentally challenging. It just is. And I think that something that I felt, and it took me a long time to sort of work through this, was that, again, maybe back to this kind of systems idea, was that there were things that happened during my treatment, which weren't necessarily part of the direct treatment, often other things that made me feel angry, right? So there was developing a fever, right? And that was always, if you developed a fever, somebody was supposed to contact I don't know if they do now. Memorial Sloan Kettering didn't have a emergency room. They had this thing called urgent care, I think it was. And somebody should call urgent care and check in there and find out. And so one of my caregivers, I developed a fever after a treatment, and one of my caregivers calls, and the first question he is asked is, well, is your loved one going to be dying at home? So I thought to myself, in retrospect, I mean, I can laugh at that, but it was just the most abysmal thing. And then I'm admitted, but I'm not admitted to the pediatric service because I'm an adult. And I end up languishing there. And ultimately, because I had a good friend who was a physician, and my fever went down within, I don't know, 24 hours or something, but they continued to sort of pump me full of fluids and they won't release me. So eventually I ended up, I mean, this is maybe one of my moments of truly advocating for myself. I ended up checking out against medical advice because, because there was a sense that they were clueless. They weren't looking at me as an individual. They weren't making sure that the pediatric team that was treating me was well included in the conversations about my care. And that's, again, more of a hospital or systems-based kind of challenge. And I think I work at a cancer center now. And so I think that while there's a lot of good intent towards patient-centered care and multidisciplinary, well-organized, well-integrated care, it doesn't always happen. And I think that's so I think I'm just glad to hear that you've always thought that way and that you think there's been progress there.
But I think the common thread through that experience of your own that you've just described is really a lack of communication with your major physicians, but more importantly, communication with you.
Right.
Explaining to you what the hell was going on at the time. And why they wanted to do this and keep you in and give you antibiotics and what have you. And so it's communication, which is the thread that is torn apart, whether it's between physicians, between the physician and his patients or other healthcare providers. That's a major thread. And sadly, that's a human frailty. And without good training, and sometimes even with good training, different personalities will respond in different ways. I wish I could tell you and reassure you that's been eradicated completely, the problems that you went through. It hasn't, but it has definitely improved. And part of the improvement is because patients, the parents of children and adolescents and young adults and others have become more forthright in asking, why, and expecting quite rightly real, not BS answers to those questions. Those are entitlements, absolute entitlements. And a long time ago, it wasn't like that. The philosophy was one of patronization and paternalism. I'm the doctor. I know better than you. I've been doing this for years. You're just the patient. You do as I say. That doesn't wash, whether you're dealing with pediatric patients or adult patients. On the other hand, the other end of the spectrum that I've seen, not so much in pediatric oncology, but I have encountered in the adult world, is as I said, the other extreme, where, especially with intelligent patients, the physician says to you, well, nobody knows exactly what's the best treatment approach here. You go and read up and come back and tell me what you want. That is totally inappropriate. It lays a whole guilt trip, not only upon the patient, the adult patient himself, but upon his family or family members that are working with him. The responsibilities here for physician and in optimal communication with the patient and family is to provide all the options, whether you're at an institution offering a particular clinical trial or not, you present what are the other options that might be available somewhere else. But then ultimately not just present the options, but if you're a physician, a specialist worthy of salt, you also come down with your own recommendation and explain that recommendation. And if you can't justify that recommendation to your patient, to the parents of a child or the older patient, then that's you're not worth it, or the trial's not worth it, or the recommendation.
Or you should go get a second opinion, right?
A second opinion. And that's very important when there are very difficult, especially in some of the brain tumors that we have to deal with children and with adults for that matter. second opinions are can be very, very valuable and very, very important. And you're entitled as a patient, as a parent, to ask for those and to not expect any repercussions. You certainly want to be treated by a physician whose ego is intact enough not to be, paranoid. That's a strong term,
Right.
but not to get huffy about you requesting a second opinion. Those days should have long passed.
Right. Well, I think you set out here what we need to establish as our kind of future medical system, if you will, or at least our cancer care system.